right, so thanks for being here, everyone. My name is Pruyn, and I am a PhD candidate in the Ancient Lab for Bionic Engineering. So I'm in the robotics program as well as the ergonomics and safety program here. And so the study I'm presenting today is pretty related to new research that I'm working on, which is a knee exoskeleton for osteoarthritis. So this paper is from a group in Michigan, and they did a very similar study to maybe what we're looking at doing, where they're using a knee exoskeleton for reducing pain and increasing mobility in everyday life for individuals with knee osteoarthritis. So what is knee osteoarthritis? There are three different parts of your knee that can develop osteoarthritis. It can be between your patella and your femur, or it can be between your tibia and your femur. And what it looks like is the cartilage breaking down and the joint space narrowing. So you start having more bone-on-bone contact, which causes pain. And so this is what osteoarthritis is. This is super common in people who are mobile and up and down a lot. If you've had an ACL replacement, you're going to probably need a knee replacement from osteoarthritis in 10 to 15 years after your ACL repair. So sorry, Jesse just got his ACL repaired. But always super common for occupational workers as well, who maybe are getting up and down off the ground a lot, squatting, lifting. And so this Michigan group actually used this knee exoskeleton for these lifting and lowering tasks. And that was actually my last journal club presentation, if any of you remember. And they saw that it reduced quadricep force for these lifting and lowering occupational tasks. And their idea is taking the same exoskeleton to reduce osteoarthritis pain. Because when your quadriceps are engaging, they're pulling on the knee, and that's what's causing the pain and increasing wear on the joint. So if we can use a knee exoskeleton to reduce the rate of osteoarthritis, we can help people return to work maybe sooner with less pain, or stay in work longer, even though they have osteoarthritis and are kind of heading for this knee replacement pretty quickly. So this is the knee exoskeleton that they used. It's bilateral, meaning that it assists both knee joints. Even though most patients that we talk to are usually only affected in one side. First, one side develops osteoarthritis, and then the other side develops osteoarthritis from overworking due to the osteoarthritis on the other side. But this device specifically is bilateral just because that's the way the design is. It doesn't function unilaterally. So they used this essentially knee brace, and they attached a motor to it. So they have at the top is the battery, and then they also have some sensors on it, the actuator, and then down at the bottom, they go all the way down to ground contact with a force sensor insole. And the FSR just tells you whether you're in contact with the ground or not. And I'm not talking about the control of this device at all. Essentially, all you need to know is it's what they call task agnostic, meaning it automatically adapts to whatever the user is doing to provide appropriate assistance. It's much more mathematically complicated than that, and we can talk about maybe pros and cons of this control based on the results, but that's essentially how this device is functioning. And they recruited 4 patients with knee osteoarthritis to perform 7 different activities. So these are the different activities, and we're actually going to watch a video. A lot of us commonly upload videos of the device when we're presenting our work. And so these are videos of the exoskeleton with one of the knee OA patients. So the first activity they did is level ground walking. You can see both knee exos on the patient. You can ignore the results. We'll go over those separately. But they also did ramp ascent and descent, as well as stair ascent and descent, and then they did standing up from a chair and sitting down into a chair. So a huge range of activities, which is great. A lot of these are high knee force activities. Things like standing up from a chair requires a lot of knee work, as well as climbing upstairs. Interestingly, for knee OA patients, some of the main activities they get pain in is descending stairs and descending ramps, because it's this really slow activity where they're weighting the knee a lot. So it's great that they tested over kind of all these conditions. The exoskeleton is not super pretty. It is clearly a research device here, and it does move quite a bit on the user. They were able to collect data using the exoskeleton as well as muscle sensor forces. So they measured the quadriceps EMG. They also did a qualitative survey, which was this modified Western Ontario and McMaster University's arthritis index scale. Basically, after each of the different activities, they rated pain and difficulty on a scale from 0 to 4, being none as in no difficulty or no pain, up to extreme difficulty or extreme pain. They said that it was modified. This is what I found online. They don't actually present the actual survey that they gave the patients, but they had the patients go through multiple rounds of each activity, climbing up and down the stairs, for example. And after every time they went up the stairs, they'd ask pain and difficulty rating, and then every time they'd walk back down, they'd ask it again. I believe they climbed stairs over and over. And they did this without the exoskeleton and with the exoskeleton, and they alternated whether participants walked or did the activities with the exoskeleton first or without the exoskeleton first. So, results. First of all, pain and difficulty ratings generally decreased. This is what they said in the results, right? And so here's the first table that they presented, which is the pain difference. So looking at if it's a negative number, then pain decreased. And they actually do a really good job of highlighting the fact that for the most part, pain was either the same, which would be a 0, or it decreased, being a negative number. And then I was reading this paper again this morning, and there are actually instances that they kind of brush over where pain does increase with the exoskeleton. For example, subject 3, their pain increased during stair descent, which, as I said before, is one of those activities that's really hard on the knees, and osteoarthritis patients do get pretty high pain during these descent activities. So overall, pain decreased or stayed the same, especially if we look at the averages across participants, which is great. They feel less pain with the exoskeleton. Accordingly, the difficulty also generally decreased or stayed the same. So in the same way, they highlight pretty highly that there are a lot of zeros here. However, there are a couple positive ones. So for subject 3, who had increased pain during stair descent, they also felt like stairs were hard, which does make sense. Here specifically too, subject 4 for ramp descent felt like it was more difficult with the exoskeleton, and subject 2 for level ground walking actually felt like it was more difficult. And this is pretty variable. We have a couple zeros, a positive 1, a negative 1. So on average, it did not help or did not feel more or less difficult with the exoskeleton, which is an interesting result because walking is probably the most common of all these activities. So if you were to wear this all day, probably do the most walking out of any of them. And so maybe walking is something that they'd want to focus on in the future and improving for these patients. So yeah, that's the one I highlight there. Otherwise, things generally decrease, which is good. That is a positive result. They also present them as bar charts, which I think was almost an easier way to look at it because it's a little more clear when we have the exoskeleton increasing certain conditions. However, these are also a little crowded, and if you're not looking super closely, you'll totally miss that the exoskeleton didn't just make everything better, which the first time I read this paper, I thought, oh, the exoskeleton made everything better, difficulty decreased, pain decreased, everything is great. And in fact, results were variable, and it is only across 4 patients, but across these patients, it seemed like the exoskeleton maybe functioned differently for each of them. And now let's look at the muscle activation, right? So they did this qualitative analysis, basically asking the patients to rate their pain and rate the difficulty. They were also actually taking the quantitative data using the muscle surface electrodes. So we can see how hard the muscle is contracting and see if that increases or decreases. So the first result they present is the mean EMG difference. So basically across one time of climbing stairs, what was the EMG? And then compare that with and without the exoskeleton. And again, here, if it goes down, which is what they bolded, and which I'm also highlighting here because it's a little hard to see with just the bolding, those are the times that the EMG decreased. Now that means it was physiologically easier for the muscles to perform that activity. And this is really interesting because about half the time it works and about half the time it doesn't work. Especially, for example, subject 4, actually it never made it easier in terms of muscle activation for them to perform any of the activities. And then if you look at the averages, it really only works during sit to stand ascent, meaning you're standing up from a chair, which is a really high torque activity. And it's something that we've seen before. We've seen that EMG reduces when you're using an EXO for sit to stand. It's something that Andy, one of our students, did with stroke patients, and we've also seen this in healthy patients. And then across participants, just looking at subject averages, only subjects 1 and 3 actually experienced overall EMG reduction. You can also look at peak EMG, which is maybe more of a standard that we use in our lab, which is where that maximum activation occurs, right? So that initial really big stretch. And here, again, about half the time it works and about half the time it doesn't. So for sit to stand ascent, it works great. We're reducing how much work the muscles need to do. And here, interestingly, subject 4 does reduce the peak EMG, even though they did not reduce the average EMG. So this is decent looking. Again, on average, we're seeing maybe more activities working well across subjects, which is exciting. Things like stair ascent, a high knee torque activity, ramp descent, a high pain activity, and something that the knee supports very heavily. And again, that sit to stand, standing up from a chair. And then this is just the trajectories of the EMGs, and the dashed black line is the exo torque, which is actually going to be this axis. It took me a minute looking at this plot. I was like, why is the torque only like 0.5 newton meters? And so one of the things that stands out here is they did not body weight normalize the torque. So all of the patients got the same amount of torque for all of the different activities. And the EMG, you can see, for example, during sit to stand ascent, the peak without the exo in red is much higher than with the exo, which is in blue. Overall, though, there's not a huge amount of difference between these EMG profiles when you average them across all of the participants. So their discussion was mainly that they're providing this acute benefit for patellofemoral OA patients. So here they're specifically recruiting these patellofemoral patients, meaning the interactions between the patella and the femur. And the acute benefit being it's an immediate benefit of the assistance, right? So some knee exoskeletons we've seen long-term, where if you train with it and use it for a couple of weeks, you might start seeing some improvements in knee osteoarthritis pain. But this is an acute benefit, meaning the patients used it for a few hours and saw that kind of pain reduction. Pain and difficulty ratings were generally correlated, which is good, because if you feel like it's more painful, you're probably going to rate it as more difficult. So the subjective feedback from the patients seemed to match in that way, right? Because when you're asking patients for their subjective feedback, you may get data that doesn't necessarily represent what's truly going on. So it's a good double check that the patient felt like it was more painful. They also felt like it was more difficult. And it may not make a lot of sense for a patient to feel like it was easier while it was more. Now, one of their main points, which was my big qualm with the paper when I first read it, was that pain reduction occurred despite increases in muscle activation. So for some of these patients, they felt like the exoskeleton was helping them, like subject 4, felt like the exoskeleton was helping them. But when you looked at their average EMG, it actually was not helping them, except for maybe sit to stand for that peak EMG activation. And so they kind of attributed this to quadriceps, to neural adaptations, right? So generally what we see with all of us, unless you happen to have knee osteoarthritis in this room, which some of you may, but basically what we expect is that your quadriceps muscle activation is directly correlated with the increased joint force on your knee and with how much pain you have from that joint force, right? So if your muscle activation, if your muscle's contracting more, you have more pain and you have more joint force. What they're seeing maybe with these knee OA patients who have less pain but higher muscle contractions is that maybe it's these neural adaptations or altered muscle recruitment patterns. This was how they justified it, saying maybe these patients with knee OA are just walking differently, right? So maybe they just don't fit the mold that we would expect to see from healthy patients, which is a fair statement, as we don't know that, and that's why we're studying it. They also talked about the fact that age and impaired motor function changes the way exoskeleton assists you and whether or not it's effective. Just something our lab has seen a lot working with stroke patients. The way that we can assist a stroke patient is very different from the way that we have to assist a healthy individual. So for these older adults, right, they worked with kind of an older population than their first study, and they saw that it wasn't as effective. It worked across the board for the young, healthy grad student subjects that they used in their first study. But when they moved into a knee-OA population of older adults, they saw that it doesn't just work across the board. So some strengths of this paper. They did have a separate acclimatization session for 2 to 3 hours, meaning the patients came in before the data collection to try out the exoskeleton and make sure it was working well for them, which is important because we know that you adapt to exoskeleton assistance as you walk with it, as you climb stairs with it. You just have to get used to the way a robot feels. They also had both qualitative and quantitative outcomes, which I think is great because a lot of the time we don't get patient feedback, and it's really nice to get a patient feedback in a succinct type of way. And especially for OA patients, pain is super important as an outcome. Interestingly, they recruited patients with patellofemoral pain. They didn't specify that they had an OA diagnosis necessarily. I kind of assumed that they confirmed an OA diagnosis, but they actually didn't explicitly say that. And they also didn't explicitly say what their inclusion criteria was based on pain rating. They didn't say, oh, you have to have at least moderate pain while walking to participate in this study, which is something that you might want to do depending on what you're studying. If you're studying something like, oh, this patient has a ton of pain going down a ramp versus they have no pain going down a ramp, you might not see an improvement if they already don't have pain. So that was something that I just felt like it was great that they recruited these patients with patellofemoral pain that were actually working with the clinical population here, because that is really important to start doing with these exoskeletons. But I feel like their inclusion criteria could have been more specific. Controller is task agnostic. This I kind of touched on earlier. It's basically a ton of math. It means you assist as needed whenever you're doing an activity. This is really cool because it means we could do 7 different activities. But in terms of weaknesses, the assistance that the device could provide was only up to 25 Newton meters peak. And as I said before, it was the same amount of assistance and the same profile of assistance given to every single participant. And the participants were 52 to 94 kilograms. So we're working with a huge range in terms of size. And for the 52 kilogram person, 25 Newton meters peak of assistance is probably maybe even more than enough. But once you're getting up to 94 kilograms, they might not even really notice it. And especially if you guys remember in the video, the exoskeleton was moving a lot next to the knee, meaning that the torque that was applied to the user was lower than what they were actually commanding, right? So they might think, oh, we were commanding up to 25 Newton meters of torque. They might have actually only been getting like 15 Newton meters of torque, which is something that we can't really measure here. And in terms of the device itself, they did note a couple limitations, just that motor is not very strong. So there were limitations in how fast it could provide that assistance, meaning the timing of the assistance may not have been correct as well to support the activity, especially if you're thinking if you're going down a ramp really quickly and you kind of collapse onto your knee, might not be able to support that motion. Also, they had to bypass thermal protections on the motor itself to even get up to 25 Newton meters, which is kind of a scary thought that they had to just bypass protections on the motor to get it to work this way. So in the future, device design is definitely something they could improve here. They also provided bilateral assistance, but didn't specify whether the patients in the study had unilateral or bilateral knee OA. I thought was interesting. I also think if one of your knees has OA and one doesn't, maybe they need different amounts of assistance. So specifying this controller to work for different patients and tuning it for them could be a way to move in the future, just to make sure it actually works for every single person who puts it on. Also, kind of going along with the device design, but they modified the interface brace to improve user comfort, which is great. User comfort, super important. You're not going to wear an exoskeleton if it doesn't come on, it's uncomfortable. However, it decreased how much torque could actually be transferred to the user, and that's why it was moving so much on the participant in the video. And then pain and difficulty ratings are something that are super subjective, and I think it is something that we need to consider with exoskeleton studies. But because a user is wearing an exoskeleton, they might just be thinking it's really cool. And of course, because they're wearing this robot, of course, it's helping them, right? So of course, they think it's going to reduce their pain and reduce the difficulty, introducing bias that's kind of unavoidable when you're working with a device that you have to wear. What I've seen in the past is having like kind of a sham condition. You provide no torque while wearing the device, and you can compare to that, which they did not do in this study. So that might be a condition to include in the future. So it's objective, and it was limited by same day protocol. I was shocked when I saw this because if you have a patient who's walking around without the exoskeleton, doing all of these high torque activities with their knee, and then they're in pain, right, because you're taking pain ratings, and then you put the exoskeleton on, you're starting from a different baseline, right? And day-to-day pain variability also exists. It's really hard to maybe standardize this baseline, but I thought it was kind of crazy that they did pain scale and difficulty ratings on the same day, one condition right after each other. All of the patients started at a 2 or lower out of 4, and then some went all the way to no pain, which could be this function of whether you wore the exoskeleton first or you walked without it first. But it's kind of shocking to me if you are starting at a 2 when you're climbing stairs without the exoskeleton, and then you put the device on and you start climbing stairs with the device to go down to a 0 pain. Because if your knee is already sore, I'd expect there to be some level of soreness. And that kind of comes back to this subjectivity and same day protocol. And then finally, just the fact that the pain and difficulty ratings didn't always correlate with the quantitative EMG data, right? So if I'm expecting, if my pain rating is going down, I would expect to see that EMG also decrease because that means your muscles are working less hard, you're having less of those knee forces. One of the ways that I kind of justified this to myself is the fact that they were working with patellofemoral patients. When I think about knee contact force, I think of tibiofemoral forces, so that tibia and femur hitting each other. And so I know when I work with OA patients, we specifically recruit tibiofemoral patients and not patellofemoral patients. And so maybe it's just a different understanding of how knee contact forces are functioning in this way. And to be clear, well, we assume as a field that quadriceps EMG is directly correlated with the knee contact force. They didn't actually measure knee contact force. To measure knee contact force, you need to do full body motion capture and you need inverse kinematics, meaning you need to be on instrumented force planes. That's how you actually know whether or not the forces on the knee are decreasing, potentially improving osteoarthritis outcomes. And they did not do that in this study. But it is great that they took pain and EMG data, and in the future, I would hope to see directly calculating these quadriceps forces as well. And also, they did not evaluate for muscle co-contraction. They didn't use hamstring EMGs, which could be maybe they're missing data. Maybe these patients that increase quadriceps EMG, it's because they're actually decreasing on the hamstrings, or maybe their quadriceps are decreasing, but their hamstrings having to do a lot of co-contraction to stabilize and balance the person still. So we're missing part of this EMG calculation that contributes to knee contact forces because the hamstrings are also critical for that. All right, that's it. I have some discussion questions though, but I'll open it up for questions.
As a non-engineering type person, is there a reason that they wouldn't have calibrated the exoskeletons to each participant? Because I feel like you'd be able to understand better what it's doing for them if they actually calibrated it.
Great question. And I think that is something that is actually kind of debated in the field pretty hotly, is whether the device should have these general parameters that work for everyone, or whether it's something that needs to be manually tuned. And I think that it works differently when you're talking about a healthy population versus a clinical population. When you're working with a healthy population, I think generally you can put on an exoskeleton. It'll work pretty well without having to do any kind of specialization. The only argument / caveat I have to that is I would body weight normalize the peak torque that you provide. And I think that was just limited here by the torque limits of the device. It just couldn't provide maybe up to the amount of torque that that heaviest participant would need. Now, what I found working with clinical populations and what I think a lot of the field agrees with is there is some amount of personalization that is required just to work with a clinical population, because everyone who has some sort of mobility impairment, it kind of functions a little bit differently, right? So as you start having pain, your gait automatically adapts in a different way. So one knee OA patient isn't going to walk the same as another knee OA patient. And being able to say, okay, you need a little bit more support during the double support phase of gait than the single support phase of gait, whereas this participant needs more during single support than double support. I think that's a really important thing that does need to be implemented. And it's something where we see it with prostheses. When you go in and you're getting a microprocessor prosthetic programmed for you the first time, there are clinicians that will go in and change the parameters. So already clinically, there's kind of this accepted standard of needing to do some sort of personalization and tuning. So I think that would be the direction to move in. Mhm.
I think you've answered the question. I just want to make sure.
Yeah.
So you're saying that it's pretty questionable to try to extrapolate from patellofemoral OA to typical tibiofemoral.
I would say it is. Generally this is still very new to use a knee exoskeleton for OA, just period. But when we are thinking about knee forces, we're usually thinking about this interaction between the femur and the tibia. And that would be something that could more likely be offloaded by a knee exoskeleton versus the patella and femur, which because it's like on the top of your leg, whereas a knee exoskeleton kind of sits to the side and doesn't adjust in the frontal plane, like it only provides that flexion extension assistance. It's something that I hadn't heard of people focusing on patellofemoral OA before. Only heard of tibiofemoral.
Which is the main
Yeah.
OA, right?
I thought it was really interesting that they recruited patellofemoral.
Yeah, I thought you go back to table 3.
Yeah.
I can do that easily, but
No, I can do it, yeah.
there was a pattern there, and I don't know if you saw that, but in terms of where the efficacy is, there's certain activities, there's a pattern. Oh, that's 5. That's table 5.
Oh, sorry. Let me go back one more time. Yeah.
There's a pattern there.
For like the activities or for the patients? For the level 1?
Ascend or descend?
Oh, for the, stair ascent decreased quite a bit.
Okay, well, just look at
But yeah,
do that.
sit to stand.
A.
Yep.
Pattern is okay, which is consistent with the patellofemoral.
Oh, interesting.
So the other thing I was going to point out is patient 4, subject 4. Do you happen to tear into that one at all?
A little bit, because I was really curious to see, because the EMG didn't decrease, if that was like the heaviest patient and maybe they weren't getting enough assistance, but they weren't.
They were at the lightest patient.
Yeah.
And they were really light. What are your subjects' average BMI for NEOA?
BMI, I don't know off the top of my head. Yeah. I know
the
that
average here is about 27.
Right, which is
but NEOA.
Right.
Patients are. And the lowest one was 19.6 patient, subject 4. And anytime you have a BMI that low, watch out for all kinds of other things going on.
Yeah.
Oftentimes, stuff up here too.
Oh, interesting. Okay, yeah. And that's like, I do think is almost important to mention is like the mental impact of NEOA, and just one of the ways that this device is really great is just if you can put an EXO on someone and they can walk more or be more active, it can have a very positive impact on mental health as well.
Yeah. We see smoking fiends and of course chronic disease issues and all sorts of things.
That's a great
point. But anyway.
Yeah.
So there's probably not enough data to do this, but knowing that you have a subject that might be an outlier, right? If there were more, like I said, probably can't detect it in 4 subjects, but you would look at standard deviations, you'd look at variation, and you would look, and my guess is subject 4 looks weird.
It would be that their data is a little bit weirder than that.
You may end up saying, you know what, we need to remove that data from our, because if you look at
something that I saw in this table, just like their averages were increased, whereas at least it worked for some activities for some patients. When you come down to peak, things get a little more hazy, which I think is why they presented both peak and mean, because both give you information about the activity, right? But peaks did decrease. I mean, this is 0.9%, so give or take clinical relevance, but it's definitely super variable. I mean, subject 3 was clearly a star player here, and then maybe for the other page, maybe that's the outlier here, but
it could be. But I think where I was thinking the outlier might be is in their subjective ratings.
Right. Okay.
Because of other factors, right?
Yeah, like if they're maybe just generally not having a good time.
Right.
Yeah.
So
be interesting. Thank you. Andy?
So I'm confused I feel like disconnected on what you're trying to say. So for patellofemoral pain, are you thinking that this method makes sense to use an exoskeleton? Or because to me, I think it makes sense.
I think it could make sense. I think it could.
And to look at the muscle activation, seeing if it's increasing or decreasing, I think makes
Yes.
a ton of more sense, just to see what kind of
Forces.
or what tension on the tendon
Yeah.
could possibly be causing.
I think it does make sense. And I think that having the pain on the top of the knee versus the side of the knee isn't necessarily my disconnect with it.
Okay.
My disconnect is more so when I think about where this is headed, right, is to biomechanically calculate knee contact force. And to calculate knee contact force, you need the force plates, you need the markers, you need and you need more EMGs. You need to know what even like your gastroc is doing, right? You need hamstrings, quads, and gastroc to be able to calculate kind of all these forces on the knee. But when I'm like envisioning where most of the painful forces are coming off of, I almost envision it more as like the bone on bone from the femur and tibia than like, I guess the patella's, it's a sesamoid bone, it's in there, but because it's the tendon connecting from the patella bone to the femur bone, I almost imagine the forces are interacting differently. I think that maybe the bone on bone forces of the tibia and the femur is what is more of an obvious solution for a knee exoskeleton. But maybe we have medical residents who can weigh in on this discussion.
That's the one who knows about
This is
Great.
fine. I've had both ACLs replaced and extreme patellofemoral pain syndrome. And the way there's an interesting dichotomy here because the typical prescription is to provide physical therapy and focus on quad strengthening, specifically like the vastus medialis, right? Whereas, and that's supposed to reduce pain.
Okay.
Whereas this knee exoskeleton almost seems like it is incentivizing
Offloading
that to improve pain.
Right.
And in this discussion of like patellofemoral versus just the tibiofemoral,
right,
it seems like patellofemoral would be more impacted by muscle recruitment, and that offloading that muscle recruitment would benefit patellofemoral more so than tibiofemoral. That's
a great point. Yeah. Absolutely. I would say an interesting point, at least when we're thinking about the patients that we recruit for this as well, we're generally thinking like type 3 type of knee OA patients who are right on the edge of starting to need to plan that knee replacement surgery. So it's giving them a little bit more time before the replacement versus I'm sure some startups would love to be, this is given to every person who has an ACL replacement and has patellofemoral pain, right? But the way we're thinking about it was more as like, yeah, you're in an extreme amount of pain and your options, when you have knee OA, your option is stay as active as possible, take ibuprofen and ice, and then you get a knee replacement down the road. And so this is trying to be like kind of an intermediate therapy where you're starting to approach that knee replacement time, and this gives you a little bit more time and a little bit more of a higher activity level during that high pain period.
Yeah.
But they didn't specify maybe what stage of OA these patients had, if they even had like an official OA diagnosis, right? So.
Anything else for Kai? I think we're at time.
Really quick. What can you take away from this study and implement into yours?
I think this gave me a lot of insight into doing pain and difficulty ratings. That's the main thing that I started reading this study for. I'm still having a hard time deciding if there's like a really good way to do it because they are so subjective. Yep. But we're going to have a multi-day protocol, I think, with ours. And then maybe this is a scale that we'll implement, but it is something I thought about it a lot, just reflecting on how to take a good pain and difficulty scale. And I think that was one of my discussion questions that we strayed from, but
there are some objective measures you could use to that point, though. You could use objective measures like the speed of ascent and descent, because somebody who's in pain will not do it as fast.
That is great.
Actually quantify functional improvements.
I think that's a great point. And maybe using those, comparing functional improvement to maybe vocal pain scores or rated pain scores would be a great way to move forward.
Hi, not to put you on the spot too much, but you wanted to mention the paper that you just got published? Just 20 seconds.
Yeah, the first aim of my PhD thesis just got published this month in Nature Communications. It's a hip exoskeleton for stroke patients. So It's super exciting. It's a kind of groundbreaking paper for the field in terms of people have tried for a really long time to use exoskeletons to improve the metabolic cost of walking in stroke patients. And this is the first exoskeleton, it's the first hip exoskeleton to do that. And it also is the first portable exoskeleton to do that. So it's a really exciting milestone. And it's great that it's finally out. I started working on it as an undergrad. So it's awesome to finally be published.
Well, I don't know if mine's as exciting, and I definitely don't have videos clips in it. So sorry about that. So almost 2 years ago, we took a look at the issue of cannabis before the reclassification even was proposed, because we just said there's been so much positive press on it. You know, it's like, well, you know, surely there must be enough randomized trials and all that sort of stuff. So we really tore it apart, and that's where this one article came out. On the guideline from the American College of Occupational. So we started out thinking it would be positive, and we didn't find that. We also find Hades a lot of problems from it. If you don't read anything else, you really ought to read the adverse effects section, which is on 862 to 863, 864. Why? Because it's a summary of the entire body of evidence, and a bunch of that stuff is just not going to get over. Because, for example, the risks of things like schizophrenia and all that sort of stuff, but are reported for the entire country of Denmark. You're just not going to overturn data sets that big in the entire province of Ontario, Canada, which is like, I think it's over a quarter of the population of Canada. So these are really solid studies and robust stuff going on. Nevertheless, of course, there's sparse numbers of randomized trials and all that sort of stuff. The other reason to bring this in, and if you've already glanced at it, you can see motor vehicle crashes and that sort of thing. So obviously there are public health implications. I've already indicated pediatrics population problems, and then the occupational health and safety, where this is all spilling over into the workforce as a quote unquote okay safe drug. So that gets us to the study, which was published only about a month ago. And so it comes out, and of course, right away, everybody's, it changes everything. So the question is, does it? Well, that's the key question for you. I'm holding it upside down.
Lucky with
that would be something I would do. Okay, so the study is a randomized controlled trial. It's done in Europe, and the blinding is not, if you read it, the blinding is not very well described, but I mean, clearly it appears to have patient blinding. It's got more complexities in it, like going beyond the randomized phase of this trial. But regardless, the main thing to concentrate on, of course, for efficacy is the blinded phase. After that, it's all downhill. The folks to get into it were 18 years of age and older, 3+ months of low back pain, which isn't very long. But that is the definition for chronic low back pain. So that's fairly standardized thing. Some people say 6 months, but 3 years. Moderate to severe pain, at least 4 of 10 pain rating. Going back to Kai's point, this one actually does specify that. And they clarify basically some prior pain management, which is not very well described, and sounds like basically if you failed ibuprofen, you're on to smoking dope. So exclusions, you can see our recent marijuana use, drug use problems, that sort of thing. Severe mental health disorder. They did not exclude anxiety or depression. It's important to note because when you get in the chronic pain area, huge proportions of people have problems with anxiety. Huge proportions have depression. What you probably don't know, at least when I was your ages, I didn't know. When you get older, everybody's got pain. The question is whether they do. They just do. You're welcome to the club eventually. It's a question of does it impact your function or not, and who decompensates people with anxiety, people with depression, all this sort of stuff. Okay, so that's the background of what goes on in life. The intervention is this compound which they titrated up every 2 days. They had a matched placebo, which sounded pretty well matched in terms of, you know, how it would have smelled and so on and so forth. This is the most of, not all of the baseline table. I cut it so you could actually see it. I could blow it up a little bit, which looks to me pretty well randomized. You can start to argue about some of this stuff when you start seeing, you know, the diabetes and that sort of thing, and the obesity and the hypertension. I mean, some of these things are not for the trial at large. You'd like to see them a little bit randomized on that. Not sure if that has impacts or not. And this is cut out of their consort diagram, which is the standardized diagram for randomized trials that everybody should be producing in this day and age. And that would be including anybody here if you do a randomized trial. Because you're supposed to say, this is the number we approach, this is what the flow is, this is what happened, who dropped out, and all that sort of stuff. Okay, because other than that, if there's not this diagram, you're on a safari to try to find it in the paper, and it becomes a dumpster dive. In this particular case, you obviously have a dropout rate which differs, right? You can see it right away in the data. And not surprisingly, and typical of a lot of pain medicines, they have all kinds of adverse effects, and so you end up dropping people for adverse effects reasons, which then becomes a problem in subsequent phases because everybody who can't tolerate the stuff starts, you know, flying the coop. So you no longer have a population of folks to approach, right? The overall scoring, looking at our criteria, I mean, I think the randomization is reasonably described with computerization. Allocation concealment is not very well described. The baseline comparability, I'm saying, is a little questionable there. Patient blinding is not well described. I presume that the treater was blinded, but it doesn't say. I mean, this is like incredible stuff. No core intervention controlled to really speak of it. It's very minimal. Compliance is not addressed at all. Dropout was obviously a problem in one of the arms. They do have uniform timing for assessments, and they do not appear to have an ITT intention to treat analysis. By the way, any of you do trials and that sort of thing and research, please include this sort of stuff. It's very easy. A lot of stuff is one sentence. Okay, raises the, you know, your quality of your study. So the overall score here isn't very good. It's almost in the low quality area. Now, that's not the only way you grade things, right? You critique it looking for other factors, but that's one of our initial ways we look at stuff. And this is the most important graph, frankly, in the paper. Anybody have any comments on it? Obviously, they differ, right? They differ during the blinded phase. Chapman, anything?
The comment I thought of is this looks very similar to exercise versus antidepressant use in depressive patients, in terms of, you see when they're randomized, it's a little slower, but we get to the same point and then it carries on together.
Okay. This type of pattern is in a lot of, to second that, is in a lot of studies, okay? Anybody see anything about the axes that don't do this?
They don't find 0.
Yeah, bingo. You see that?
Yeah.
In order to magnify the difference and fool you, they changed the 0 to a 2.
Yep, makes it look bigger.
Makes it look bigger than it is. Okay. That is really, that's amazing, quite frankly, to go in this kind of journal.
Yeah.
And get
Gonna be
past
okay with it.
reviewers.
Yeah.
I was gonna ask, it has a huge impact factor, this journal. Why do you think they?
I know. The reviewers screwed up. I mean, that's pure and simple, the reviewers screwed up.
Even really good journals will publish things that have
Yeah.
problems.
A lot of barriers, yeah. Especially if it's cutting edge and it's sexy and all that sort of. mean, seriously. There's a little question here about the differences, but you can see that they expand, so I'm not that concerned. But always watch out for the baseline comparability of your outcomes variable. Not just the demographics variable, but the outcomes variable to have. So our strengths are, an attempted blind, which they, by the way, never assessed. I mean, that's another mistake. You should always assess, because this is a study where it's going to be unblinded to some extent, because some people are going to get foggy brained, right?
Yep.
And they're going to know right away, I'm probably doped up. Hello. Okay. No assessment of blinding success, and partial unblinding. Most of this other stuff, I'll let you read this. The entrance criteria are not evidence-based. Okay, they did not. I mean, chronic pain, you're supposed to have managed people with exercise, cognitive behavioral therapy, acceptance commitment therapy. There's all kinds of other things to have done, and they didn't do. So it's like, okay, so to whom does this even apply? That is a generalizability problem. The dropout rates, roughly 85 versus 69. Obviously significantly different, and you have a 17% adverse effect rate. Done quickly here. The reduction in the pain rating. This is the key one. Mean difference is 0.6. All right. What is it for opioids? It happens to be 0.69. Opioids, we already know you no longer treat people with back pain. It's not to be done. It's a bad drug. The minimal differences in a disability questionnaire that's not objective measure, that's a subjective measure. And Jason Bussey, who is the author of the opioids paper, this is systematic review and meta-analysis. Jason is at McMaster's. He's going to be here in a week at a conference in town. But anyway, 26,000 patients. So, there's your 0.69. And of course, they say no signs of withdrawal and all that sort of stuff. If you read the guideline, there's all kinds of problems with withdrawal, dependence, and all that sort of stuff. And a randomized trial is too short of a period of time. You can't assess that. It's too small a population of people to actually have the ability to answer that question. So, of course, they come up with that wonderful conclusion, basically, therefore it's safe and effective. So I kind of biased you in this, but so that is my presentation, and now I go to, and by the way, there's going to be disagreement. I'll tell you, there's all kinds of people who are going to say, "Oh, no, we should be prescribing this."
Legalizing, prescribing, and so forth.
Yeah, but we've got this background of huge problems with adverse effects.
Yeah, how could they draw the conclusion that it doesn't have other effects when they even present to you or present in the article these adverse effects? Like, how do you draw the conclusion this is safe and effective? I mean, opioids have their own set of adverse effects as well, but
And I should let me first say I wish that stuff would work. Right? It'd be really great. Another drug that's useful.
Yeah.
The problem is that we are sitting here with not very good data and not a very good result.
Yeah.
When people put, therefore it is safe and effective, it's almost like a regurgitated sentence. It's typically put in industry-sponsored trials. I'll say it. That's usually where you see it.
Yeah, not that we should prescribe opioids, but the adverse effects that they identified there are consistent with the issues that they're having with impaired drivers and such in areas where cannabis is legalized and so forth. And so I guess I wonder, does the benefit, the negative 0.6 benefit sufficiently outweigh the additional risks associated with prescribing
Occupational safety health stuff.
right? So you get them, you get them behind a wheel, whatever,
These are major risks.
Yeah.
This is not, 52-42 different disability rating, a subjective measure.
Yep.
But dizziness, 8 times, sleepiness 12 times.
I think there's certainly a problem with the like conclusion that like, oh, weed makes pain go away and also has no like downsides. But I also think pain relief goes a long way in improving outcomes in a lot of people.
Sure.
And like,
Yeah.
if you have like this debilitating pain where you're in bed and your option is like, well, okay, if I take Advil, it doesn't work. If I take opioids, there's all the problems that come along with opioids. I think cannabis offers like a middle ground solution where it helps relieve pain. And yes, there are side effects. I think the like safe and effective thing is like, yeah, obviously there's a bunch of evidence that there are side effects. But I think when compared to opioid side effects and especially opioids dependency issues, I think they're orders of magnitude different. And so I think if this is like an option of like, okay, you're either bedridden in pain or we prescribe you opioids or we prescribe you cannabis, I think cannabis comes out on top.
I think you have to actually read the article, the guidelines of the article, and come back to talk to me about that.
Yeah.
Okay. Because I'm not sure that you're gonna sustain your opinion after you read all that.
From the pain perspective or the side effects perspective?
Yes, and I did not have this original opinion, but we did all this research. Because I went into it without bias, I went into it with what are we gonna find? Okay, and what I'm seeing is the opioids thing all over again. And other researchers are all saying this is looking exactly like the opioids mess all over again. And the people initially were like, oh, rah, prescribe it. And then later on, mess. And that's what it's looking like.
I will say, I think part of the opioid crisis was definitely like the companies really pushing it, but aside from opioids, I feel like opioids are a weird comparison to make with cannabis, and maybe that's just because I don't know enough about cannabis, but I've always seen it as like similar to alcohol. And people have, I'm gonna say, less harsh opinions about alcohol when you compare it to like how they see cannabis and weed and stuff, which is interesting to me because you're like, oh, it increases car crashes, and I'm like, we still sell liquor, like you're still doing a DUI, like
We don't prescribe.
yeah, but I feel like it's weird to like have the argument about cannabis without bringing up alcohol and how society views both.
I think the trouble is alcohol is so ingrained in society for so long, like, since we've been there, that's the trouble. Like, we know it's a problem. I think we've known it's a problem. They tried prohibition, it didn't work, so I think.
Well, I mean, I think part of
I'm
it
not-
is
And that's, I agree with you.
yeah, I think a lot of like the reason why alcohol is like a little safer than like weed is the legalization aspect, and how when it becomes legal, it's more easier to control. And you can like make sure everyone's getting like safer strains or whatever, and then that way it's not just, hey, I'm buying it from my guy on the side of the street. Or
Let me,
whatever.
there's a sequence of questions here. Let me point out a couple things. One is the potency is currently at around 18% THC. In the 70s, it was 3%. Okay, it is infinitely more hazardous now than it was. Second thing is the cost to society in terms of schizophrenia is going to be astronomical because you're talking about 3 to 4-fold risk. You are next.
Really brief comment. In the acknowledgements, it says that it was sponsored by Vertanical. Vertanical is a Munich biopharmaceutical company based in non-opioid cannabinoid-based therapies for chronic pain.
Interesting.
And so it says that they contributed the funding and also with medical writing. To me, that's a, hey, let's throw some cash, right? Like that's a huge red flag.
Ready to help us out.
Yeah, huge red flag, regardless of
You're
the
not
outcome.
supposed to, I agree with you.
Yeah.
Thank you very much. You're not supposed to have them helping to write it.
Yeah.
Chapman. Thank you.
And I kind of go into the point of like, the Purdue organization and the opioids. There is also that going on in the cannabis industry, like the
That's right.
perception of that is there, it's not like this
It's
isn't
getting pushed.
organized.
Well, I will tell you so, okay, put on a different hat, I'm doing this firefighter cancer screening project. One of the guys said, well, basically I called the EAP I won't mention the department, EAP is Employee Assistance Program. And basically said that they were pushing marijuana. Pushing it. I was like, oh, crap.
You okay?
you know? So there's a societal, it's very similar to the opioids thing at the beginning, all right? And we were getting pushed, and it wasn't working. And I will tell you, I just came on the issue myself clinically because I was like, this is not working. This is really bad. And I finally backed away before, everybody else backed away. But yeah.
Even this argument from a rhetorical perspective in the introduction of the paper, it says we're doing this because anti-inflammatories have certain dangers and opioids have certain dangers. And so let's look at this, but it doesn't, it would have been more on the level if it would have said, been upfront about here are the downsides that we're saying with cannabis. And so let's then weigh the upside versus the downside the same way that we weigh the upside versus the downside with anti-inflammatories and opioids. But it didn't, from a rhetorical argument making perspective, it didn't go in that direction.
And then I point out just again, big picture. This is an example of what happens with a high visibility article that gets published because it's topical. And you think everybody's objective in medicine and science. Like, oh, not quite.
I was just gonna kind of go back on what Dr. Aikman said, because he said that, it's not really an argument about whether it should be legal right now. It's more about should it be prescribed by doctors as a useful medication. So I think talking about legalization is a whole different thing entirely.
Well, it is in the occupational safety and health realm, unfortunately, and there's some data I also put in that guideline. The problem is people who use are no different in a way than the alcohol folks who then want to drive a car right away when they're impaired. They do. And it's a high percentage won't do it. It's more than 50% are doing this kind of stuff. And it's like, oh, this is going to be lovely. So you really want to be in a workplace with overhead crane operation and have that guy on drugs. What about the truck driver? You want to have them on marijuana? Driving down the road next to you? Think about that. Because that's where this is headed right now. Chapman.
I'm not super up to date on like addiction science, and I don't know, maybe Dr. Chang is online, but I want to raise the question of the alcohol or the cannabis use disorder described in this adverse effects section states that the criteria of being at least 2 of 11 criteria within a 12-month period. Is that similar to how we assess alcohol use disorder and opioid use disorders?
Yeah, it's getting beyond my area of expertise. Somebody else may know, but I don't know.
In terms
of Patrick.
I just draw from the occupational safety and health perspective. So at least in the US and Canada where marijuana is legal, if you still test positive for cannabis on any kind of drug test, you will not work, or you'll go into some kind of program.
It's yes, and at the same time, what has happened in the past is EEOC eventually says, oh, it's a disability. You need to let the person do it anyway. That's pretty much where the push comes. So, and that's already happened with opioids, by the way, in truck driving. So, we've got people on the road on opioids who are not operating with all their faculties.
Yeah, I would add, but then it gets into a very legal situation. So those individuals go get an attorney, and then the arguments come in, what is impaired?
Yeah.
Right. So
exactly.
Yeah.
Exactly. Yeah. And the evidence says, with opioids, you got at least 50% to double. It's about double crash risk. So it's not a minor issue on a public health population basis.
I'm curious, so with like the opioid epidemic, which I feel like I know more about than what's currently happening with cannabis, feels like there was this huge opioid industry outside of the country that was able to put a lot of money into the promotion of like, opioids are awesome, everyone should get these. And I guess maybe I'm misunderstanding how big the cannabis industry is, but do you think, okay, so you think that it's the same effect of like money pouring in to be like, this is safe and effective and everything's great?
Yeah. Okay. Well, let me give you another anecdote. Okay. There was a bill, and you can look at it online. I forgot the number. There was a bill introduced in the Utah State Legislature. The legal limit for impairment intoxication in Colorado is, 5 nanograms per ml. Okay. The bill was introduced to increase that limit in the state of Utah to 20. Industry lobbyists wanted to produce 20. Guess what the amendment to it said the number should be?
Don't say 50.
Bingo! You got it! I
That's
love it!
actually ridiculous.
You got it! 50. I had to spend days digging around in literature to rebut this, to get evidence into the hands of other lobbyists to go backwards and ultimately go to the legislator who proposed it, so he could go back and tell the industry folks they were lying to.
I don't really know how cannabis dosages work. Is that like, how impaired is 50? Is that like can't stand up straight, or is it like?
Well, and good question. So the number 5 came up in Colorado because they said they had to have one. They just drew a line. That's how it started. Well, that is called expert opinion, and you do the best you can. There's nothing wrong with it if in fact there are no data, because you just get people together and you say, "What do you think?" That's how that happens.
Yeah, but now we do have data.
Now we do have.
So,
Yes.
I really don't want to toot on the horn again, but it's crazy to think that a company that makes money off of cannabis funded and wrote part of this article.
And then it's not
To
more
me, like,
obvious.
it's just not like
First
the
time.
fact that, yeah, I don't know, it's crazy.
Well,
that-
somebody can look up the altimetrics on this. It's gonna be very high. 'Cause it got a lot of press.
Yeah.
Went all over the place. Things are published.
I was gonna say, obviously, we're running out of time, but the other distinction that I would say makes this a little bit different than opioids and in some cases more pernicious is that culturally, there is obviously a view of cannabis that, opioids, there weren't movies being made about, oh, let's, take opioids and have a great time. But I was like, we all love Seth Rogen, he's a very funny man, and like all these, so there's like, it's a different thing that makes it culturally more acceptable and all that stuff too, so.
The one area of efficacy that appears to be spasticity for multiple sclerosis. Spasticity for multiple sclerosis, which by the way got morphed into neuropathic pain, which got morphed into back pain. So they just sort of by pathology said, okay, there was like effective for back pain. Yeah. One last question.
I was just gonna say, in terms of like maybe finding ways to standardize this would be trying to link some of these ways that we assess what disorder status is, because a lot of those items were like daily life. And so you could find the parallels of what severe use, alcohol, like severe alcohol use disorder or opioid use disorder, so how much that burden is on the public. You could actually really start changing some minds on this, because I agree, like something that gets marketed, maybe not marketed, but like the cultural phenomenon around a generation is that, well, if you don't want to partake in drinking because that's bad for you, here's the alternative. Like it's not that bad, and if you want to have a good time, like that's the better way to go. So
Well, if you think it's safe, I will talk to you about my nephew. I have a nephew who just got this problem, and he becomes psychotic. So psychotic, my sister, my mother would be freaked about this. My sister is afraid that he is going to be walking past her with a knife. Okay, that's how dangerous this is. And he's been through rehab now 2 or 3 times over this, okay? And now banned from, coming into the property and all this sort of stuff going on. Because at one time they had to get 2 former military guys with guns to, oh yeah, let me tell you, this is going on all over the place. People aren't talking about it yet, but it's a disaster. That's why the schizophrenia I mentioned is going to be where the money really hits the road.
As an engineer, I'm totally a schizophrenia expert. But don't you have like isn't there some sort of like biological disposition to schizophrenia, which is then impacted by these hallucinogenic drugs?
Probably. We don't know the mechanism, but
why it like increases the chance.
right. And
It's not necessarily everyone. It's just
so one of his great uncles happens to also have had schizophrenia. Okay. And yet he doesn't have the psychosis off of the drug, but he still goes back on it. This is so addictive.
Another problem too is that schizophrenia presents earlier on in life, the time when people are
That's
more
right.
likely to be using drugs, and
That's
so it
right.
would impact. I mean, if
Yeah.
Dr. Hegmann was up there getting a party and having fun, his likelihood would be so much less than one of us, which is another part of the problem.
That's an assumption.
He's actually already hearing the voice.
He's older than 25, so he's good. What are alternatives to opioids
Yeah.
and cannabis? And
I'm on this slide, but anyway, the criteria should have been, aerobic exercise, progressive strengthening exercise, because it's almost all back pain related, and, cognitive behavioral therapy and acceptance commitment therapy. So people actually learn how to, back pain's normal. This is what you do, and this is how you overcome it, and this is how you continue in your life. Okay, that's how it should happen. And there are going to be very few people after that who need significant drugs.
Just curious where maybe like surgical intervention falls in there, like if you have like is that completely separate, like, cause it's more like maybe acute injury related, or?
They correctly removed the people who have radiculopathy and a pinched nerve. Okay, after that, the back surgery doesn't work. So if you've got relatives, you already know that. They still, what if they had chronic pain before surgery? What do they have after surgery?
Still chronic pain.
Chronic pain. Yeah. So we've gone over.
Hey, everybody, thank you all so much. Great discussion. Next week, we may be in this classroom, we might be in the auditorium, so TBD as of now.